Hello and welcome to this special webinar on a very important topic of rising to the challenge of inequities in lupus. Thank you for joining us today and thank you for your support for the Lupus Forum. To be joined by three extremely expert and experienced speakers today who've worked extensively in this area. So I'd encourage you to listen to what they've got to say and also think of any questions you'd like to ask them to learn from their experience. So my name is Ed Vital. I'm the chair of the Lupus Forum and I work at the University of Leeds in the UK. And I'm also joined today by Professor Laurent Arnaud, who works at Strasbourg University in France, Professor Vibeke Strand, who works at Stanford Medical University School of Medicine in the USA, and Professor Guillermo Pons-Estel, who works in Argentina. So just a few things to be aware of. So you're going to be on mute during the meeting, but please do think of any questions you'd like to ask. You can access the Q&A function on your screens as you see illustrated there, and you can enter questions at any time during the webinar. We're going to be looking at those and trying to get through as many of them as we can, but the Q&A section is at the end of the meeting. So just enter them as you think of them, and we'll come to them at the end of all the presentations. Also, bear in mind that if you attend the webinar in full, and you'll get sent a post-event survey, then you can complete that, and you'll get an accreditation certificate for this piece of professional development. So what are the learning objectives for today? So our overall learning objective for today is for us to understand the key inequities in accessing lupus treatment and to discuss from multiple perspectives the possible solutions to these inequities. And just to go down onto specifics, some of the things we're going to be looking at, we look at the key social determinants of health and how these influence the presentation, management and outcomes of SLE. We're going to look at genetics and race and ancestry and how that influences susceptibility and severity of lupus across a range of different ancestries and populations. And we're going to look at the dilemma of balancing disease control, immunosuppression and infection risk in SLE with special consideration to patients in low and middle income countries. And this is just an overview of our agenda. So I'm going to give you a very brief few minutes overview of the key topics that we're going to cover over the next few slides. And then I'll hand over to our speakers who will speak for 15 minutes each on social determinants and clinical outcomes with Professor Arnaud, race, ancestry and treatment outcomes with Professor Strand, and the dilemma in disease control with Professor Pons-Estel. So let's get straight into the interesting part. So what are the subjects that we're going to focus on today? What are the main inequities in lupus? This is a big subject, and I tried to think about it and how to organize it. So I think we could talk so as you know, these are our three talks: social determinants, race and ancestry, and low and middle income country populations. So why is this such an important subject in lupus? I think the reason this is a bigger issue for us than it is for other medical specialties is because of the heterogeneity of lupus. It's one of the most heterogeneous of all conditions in the whole field of medicine. That might be the clinical features. You've got some patients who have an isolated A negative rash. We've got some patients with severe multi-organ disease, all within the same disease. And that may be driven by differences in immunopathogenesis. We've talked about this many times on the Lupus Forum, that sometimes we see really severe systemic B-cell activation, and some features like skin disease may be more related to local tissue innate immunity. And underlying all of that, we've got a complicated genetic susceptibility. There's more than 100, probably more than 200 susceptibility loci, which work in different parts of the immune system or not even in the immune system. And it's a very polygenic risk. And we know that risk can influence the clinical features and the response to therapy. And also that response for the therapy can be very variable for clinically similar patients. So all of this variability in this disease means that other extraneous factors, like the personal circumstances of the patient, can have a very big effect on their outcome. Some of the main subjects. So we see a lot in lupus studies talk about race, ethnicity, and ancestry, complex terms that can be used interchangeably, not always appropriately. They have slightly different meanings. Race has been described as a social construct based mainly on physical attributes, whereas ethnicity is more of a social term that relates to common cultural attributes like language, religion, or nationality that can only really be self-reported by the participant, whereas ancestry is a term that seems to emphasize more genealogic, genetic, or perhaps just geographic descent. But these terms can be mixed with each other, and that can cause a lot of confusion. And it's also important to note that when we see something that we think is associated with a person's ethnicity or a person's ancestry, the true reason for that may not be anything to do with something like genetics. It may be to do with a geographic environmental factor like UV light or infection. It could be due to socioeconomic inequality. It could just be due to differences in language and education and understanding of the disease. It could be due to cultural beliefs about health, or it could be due to other diseases that are prevalent in these populations, like hypertension, that can affect outcomes of lupus. A complicated question. And even if you take some terms that we think we understand that are commonly used in lupus trials, like Black, African, or Asian, which are commonly used to stratify lupus studies, they really don't seem to be very adequate to describe the problem under study. So if you just take, for example, you describe people as having African ancestry, that doesn't really accord with what geneticists tell us about the genetic family trees that you see on that continent, which are actually extremely varied between different parts of the continent and overlap with other areas like Eurasian or European. And this problem is just as bad if you take a term like Asian, where South Asian and East Asian may be very different, not just in genetics, of course, but also in all those other aspects we talked about, like the cultural and ethnic aspects. When you come to socioeconomic factors, again, I'm not just talking about lupus here, I'm talking about all medicine in general. You can see some really strong relationships between aspects of society and lifestyle and health outcomes. So there's just a few shown on here, but you can see the strength of the relationships. Just take educational attainment, less than high school, some college, or college is just in the USA, and you can see a strong association between life expectancy at age of 25. Or on the right, you can see the family income and the percentage of federal poverty level being associated with the percentage of people who are suffering with an activity limiting chronic disease. Once again, strong relationships, but the reason for these relationships could be quite complex. And although these terms are quite difficult to understand sometimes and use, they do seem to have a big impact on the outcome of lupus trials. So maybe we're not coding them as well as we could, but if you look at the ARMS trial, famous landmark trial that showed us that mycophenolate was a similarly effective treatment option to cyclophosphamide in lupus nephritis, you can see that when you broke it down into the groups they chose, overall, Asian, Caucasian, and other, then there seems to be some important treatment effect in this other group. But it'd be quite difficult for anyone to know whether that applied to them or not. Similarly, when in the belimumab studies, there was a study specifically done to assess the efficacy in what they called Black African ancestry patients, but the result is quite complex. Overall, the study didn't quite meet its endpoint of showing the efficacy of belimumab in Black African ancestry patients. But then when you split that subgroup into those patients who are in the USA or Canada, or those who are in the rest of the world, you see a completely different response pattern, again emphasizing that things that are associated with something like race or ancestry may actually have other explanations. And we mustn't forget, of course, the importance of understanding lupus across the life course. So a lot of research we do in lupus and a lot of trials are done in adults with SLE, But this creates an inequity for children. And that's a big problem because children have worse disease activity, they have worse damage, they have worse mortality, but a more limited evidence base. Belimumab license came 8 years later for children than it was in adults. And even if we go away from drug studies, something like treat-to-target studies, most were conducted in adults, but why shouldn't they be conducted similarly in children? Some of the instruments we use might not work so well for children. For example, quality of life instruments, some of the questions are not appropriate for children. And there may be issues in health provision, like insurance issues, that change when children become 18 and have to have their own insurance rather than relying on their families. But saying all of this, there are many challenges here, but there are many opportunities too. So we're all learning that we're able to communicate with each other better, and we're able to run collaborative research projects across much bigger world regions that can help us to understand inequalities rather than focusing on just our own countries and the patients around us. When there are inequities, having a greater range of new therapies should allow us to address them, especially where there might be differences in the biological mechanism of disease between different patient groups. And there also might be strategies like treat to target that can improve outcomes without relying on expensive drugs. I think, again, a function of the online world and the medical education that we're doing right now can also be that there are more resources for patients that can improve their health literacy, their ability to use the healthcare system and get the best care for themselves. And I know for myself in the UK, we're now engaged in trying to run clinical trials and guidelines that cover the whole life course rather than only specific age groups. So this is just a very brief overview of the issue. And next, I'm going to hand over to our first speaker. So our first speaker is Professor Laurent Arnaud. Professor Arnaud is a professor of medicine at the Strasbourg University School of Medicine and a senior consultant in the Department of Rheumatology at the University Hospital in Strasbourg. And he's going to speak to us about social determinants and clinical outcomes. Over to you, Laurent.
Thank you very much, Ed. Thank you very much to Lupus Forum. I'm very happy to be sharing this time with you and talking about these social determinants of health and the clinical outcomes that are related in the context of SLE, because this is such an important theme. And actually, I just would like to start with a interesting thought, which is that you can provide very equal care, but in the end, it raises some inequities. For example, if you give the same duration of consultation to everybody, well, you have subgroups within the population who may need more time, and this will lead to inequities. You are thinking about being equal, but in the end, it raises some inequities. So I'm just going to take control of that screen and move forward. These are my disclosures. And I would like to highlight the learning objective. And I really think that for tonight, the first learning objective is to understand the impact of these social factors on health, and especially the long-term clinical outcomes in the context of lupus. I would be very happy to highlight intervention and describe the implementation of these interventions in modern clinical practice. But we all know that these inequities are strongly rooted in our society. And if there were simple answers to these questions, I think we would know that already. I also would like to highlight some of the instances and some of the options that we have should actually be played at the political level, at the policy level, health policies, but more generally, life policies. And so it's not very easy for doctors to solve all the problems by themselves. So I think that if I had to quote one word that is really connected to these social determinants of health, is the complexity. We have a very complex picture in front of us. When you think of all these social elements of health, social determinants of health, which are broadly defined as the conditions in which the people grow, they are born, they work, they live, they age, we understand that they are strongly interconnected. But what is sure is that this has a substantial impact on the disparities that characterize SLE. And we doctors always think that the medical care that we provide is the strongest predictor of the health outcomes, but actually it's not true. It's only a minority. Most studies concur to say that these social determinants of health are responsible for 1/3 to half of health outcomes. So that is a very good reason to take care of that. So I have just chosen 4 examples that I would like to highlight in the context of lupus, or more generally in the context of societies. And the first one, which I believe immediately pops in mind, is the income. I don't know if you know that fact, but each 1% rise in income inequality in a society, so that's the difference between the rich and the poor, it is linked to a 4% increase in death, among the persons who are on the low end. So we see that there is a very strong leverage here related to income, and obviously that is not something easy to solve. Then there's the role of education. And again, if you take the population as a whole, the most consistent predictor of death at any given year is the level of education. And if you take people from the general population between 45 years old and 64 years old who have the highest level of education, their death rate is 2.5 lower than those of the person of the lowest education categories. So there's a very strong association. And finally, there are other elements I'd like to quote from the previous figure. One is social isolation and coping strategies. Socially isolated persons have a death rate of 2 to 5 times higher than those who maintain close ties to friends, family, and community, have a social tissue that is actually well functioning. And finally, and this comes back to the impact of medical care, during the course of the 20th century, we have gained around 30 years of life expectancy. And it's interesting to know that only 5 of these 30 years are actually directly due to the medical care, the improvement of medical care. So I think this really highlights that many of these elements are intertwined, but also that this is very, very complex. So I'd like to start with a small focus on these socio-economic factors. And I think we will agree that it's a very multidimensional construct. There are many layers, such as the income, the education, the employment status. But what is sure is that we have robust SLE data showing that SLE patients who have this lower socioeconomic status, they have worse outcomes. They have significantly lower retention in care, which means that they disappear from the care system, and they also have poorer survival altogether. So when I was preparing the slides, I reviewed some quotes from patients, and some of them were very enlightening. And I think it's important to highlight that many of these studies are made or based in the US. And what we observed in the US may not be completely translatable to other areas of the world. For instance, regarding the lower retention in care, I remember a quote from one patient. She was saying, "I am afraid to go to my rheumatologist because I have to cross the neighborhood and I'm afraid to be shot." And obviously, we don't have that kind of things in Europe, or at least not of that acute findings. So these results, I think, should be interpreted in their context, which is the special context of the US. But for sure, we know that SLE has a very strong impact on employment, for instance. You see this figure on the left, which is the proportion of patients with SLE who are being employed. And you see that actually it decreases very fast. And we know why. It's the very strong impact of the disease upon work capacity through fatigue, through pain, brain fog, and other manifestations such as the flare, which may necessitate an hospitalization. So we understand that we are promoting or hoping for more economic stability, but it requires adequate employment. and also other elements, just food security or safe housing. But again, this is not so easy to obtain at the population level. And these elements are direct predictors of access to healthcare. Obviously, reduced access to healthcare is absolutely central to patient outcomes. This is true for the diagnosis. You have that on the left. Delayed diagnosis means delayed treatment. This is also true for lupus patients needing treatment. If whatever is the reason, health policies, a treatment is not available, then the portion of patients being able to receive this treatment is decreased and the outcomes are not optimized. So there are potential intervention, of course, for instance, telehealth for remote patients, but regarding access to drugs, medications, then is obviously more complicated. So I just want to say that the impact is very clear. And for instance, there are studies showing that you have worse outcomes, which are observed for patients with increasing distance to rheumatologists. And we understand that this is especially important in the context of rare disease. So this is where we have some solutions such as digital healthcare. We know that we can now organize remote consultations, although this is not perfect, but at least the remote patients may nevertheless access healthcare. So despite these new elements, such as telehealth expansion, there are other models to facilitate access to care, and I'm thinking about community-built healthcare models. There are subgroups where access to care is limited because there are some cultural differences, and obviously placing rheumatologists in local community, such as health centers that are locally situated, where you have social workers that are able to engage the patients, may result in better outcomes for these patients. So it brings us to another very important aspect, which is the cultural and the language barrier. We know that these are the communication difficulties that are caused by differences in language, of course, but also beliefs or values. In some cultures, taking a medication is actually like taking poison. And there are actually cultures in which this concept is not there, but this is what is actually felt by the patient. And so we have data regarding these aspects, again, especially in the US, and they relate to what is broadly called the racial background, which is, as we said before with Prof. Vitale, a word that we don't really like. But regarding therapeutic adherence, several studies concur to show that African American patients have lower therapeutic adherence to Caucasians. And we immediately understand that this is complex. It results from income, belief, health literacy. This is a very complex mix. And as a mirror to this, in the US, studies show that Black women with SLE and limited health literacy have worse clinical outcomes. And this is why I think it's so important to tackle these subjects. So there are some potential interventions. I mentioned a community-driven care, the role of peer support groups, but also something for the doctors, which is cultural competence in some areas where the doctors may also benefit from specific training. And of course, there are some more straightforward possibilities, such as the use of medical interpreters that we sometimes do use when it's needed. Something I believe is so important is to provide the patient education materials in multiple languages. And it's true that many initiatives, I'm thinking Lupus Europe, I'm thinking RIP-Connect, I'm thinking several projects we are driving now, are deployed from the start in multiple language to really reach this community and engage them better. So I think I have listed most of the key interventions that we have, but I would like to support or strengthen the importance of the peer support groups and especially patient associations. They are usually representative from different cultures, different languages, and although they have their own challenges in the access to the patients that are the most deprived, I really think that giving the connection points for these is obviously a very important element. So the social support is absolutely key. And we know that, for instance, studies show that, again, in the US, for African American lupus patients with high burden, lack of support is associated with a higher psychological load due to the disease. So there are some elements that we can help with as doctors, but obviously the role of peer support programs is absolutely key to facilitate connection between the patients, but also between the patients and the healthcare providers. A quick word about the environmental factors. We know that these are the external, physical, chemical, biological elements which will impact the aspects of human health. And I just want to quote smoking, which is highly prevalent worldwide. We know that the risk and severity of SLE is strongly increased in smokers by around 50%, and also that the efficacy of HEQ, hydroxychloroquine, is again strongly decreased in smokers compared to non-smokers. So these factors are not fully characterized. Potential intervention for some of them are complex. But for instance, for tobacco smoking, as doctors, we absolutely need to emphasize that there are some interventions that we can support. And this is very much related to these psychosocial factors. We know it's the characteristics that will influence an individual psychologically or socially, and they are strongly associated with manifestations such as fatigue. And we know that fatigue is an important mediator of impaired quality of life in lupus. So this is an additional reason why we should take care of these aspects. I just want to highlight other elements, especially the role of mental health services, but also the role of digital therapeutics, which may help us tackle some of these manifestations. Just as a conclusion, I would like to highlight that there's a broad range of social or societal determinants, and these have very significant impact on lupus patients' outcomes. Actually, the importance of this factor is much more significant than the isolated impact of medical care. And there are some interventions that could reduce the impact of these ADH on the clinical outcomes in lupus. So I think today is a good day to really understand the burden of these elements and start improving them. Thank you very much.
Thank you very much, Laurent. It's an excellent overview and a great way to start off this webinar. So again, I'll just remind people to just, if you have some questions about what you've just heard, to enter those ready for those to be discussed later. But before we can do that, it's time for us to hear from our second speaker. Our second speaker is Professor Vibeke Strand, who's an adjunct clinical professor in the Division of Immunology and Rheumatology at Stanford University School of Medicine in Palo Alto, California. And Professor Strand's going to give us a talk today about race, ancestry, and treatment outcomes. So I'll hand over to you.
Thank you very much, Ed. And as noted, I will be speaking about this. There's a lot of heterogeneity in lupus, but there's a tremendous heterogeneity also in the effects of race and ancestry and social determinants of health. These are my disclosures. So our learning objectives include understanding the divergent prevalence of lupus across the globe. It is quite divergent, and highlighting the impact of ethnic and racial differences in this prevalence, as well as the incidence of disease. There's differences in clinical outcomes across these divergent races and genetic ancestries. And because of this, we have a tremendous disparity, not just between disease prevalence, but also in terms of participation in randomized controlled trials. So I want to review the prevalence and incidence globally, and it's a very wide range. So if you look at the left figure first, you can see that the light blue, gray, purple are all the countries for which there are no prevalence estimates for lupus. And then you can see that there's multiple differences here. So if you look at the highest prevalence, which is 5,000 per 100,000 patients in red, that's actually Senegal and Uganda in Africa. If we move to the 1,000 to 5,000, which is orange, you can see that this is Nigeria and Kenya. So again, we're still in Africa. But as we go down, 250 to 1,000 patients per 100,000 is yellow. And that's Ivory Coast and Cameroon. And now we move to the rest of the world. So light green is in Spain, where it's 150 to about 250 per 100,000. 100 to 150 is green, and that's Portugal next to Spain, but also Greece. 50 to 100, which is light blue. As you can see, that's largely Canada, but also Colombia, the UK, Hungary, and Sweden, Australia, and Argentina. And finally, the 0 to 50, the smallest prevalence is noted for China, but also France, Germany, Italy, Denmark, and Ireland, and Korea. But what's very interesting in gray is the United States, which includes Alaska, and that's the widest range of all the prevalences. And oftentimes it's the highest prevalence in the world. But remembering that the blue, gray are all the countries for which there is no data. Now, if we look at the incidence rate, it's somewhat similar. So you can see 10 per 15 per 100,000 actually is Australia, and due to their native population. 5 to 10 per 100,000 is Argentina and Greece in orange. 0 to 10 is US, also Dubai, United Emirates, and Taiwan, very small, but located on the map. And 0 to 5 is UK, France, Italy, Hungary, Denmark, Sweden, Estonia, and Korea. And may I remind you that for some reason, India is missing from this map. But what was reflected of this prevalence and incidence is in the United States, the overall estimated female prevalence of lupus per 100,000 is highest in American Indian and Alaska Natives, 271. Then Blacks by 231, Hispanic 121, compared to Caucasians, 85. So here are some other differences that may explain why we see such disparities in prevalence and incidence. If you look over on the left, there's actually 5 areas from the United States where we have epidemiologic data. At the very top is Puerto Rico, followed by Alaska, which of course is Native Alaskan Indians. And then MCO for United States is a managed care organization across the states. Then if you go down several more, you'll see USA Georgia, which is a registry, as well as USA Michigan, which is a registry. And you can see quite the range of the prevalence in these different epidemiologic studies, which are also reflected in the incidence on the right. So we know there are significant racial and ethnic disparities in lupus prevalence and incidence. And we see that overall, the highest increased risk is observed in Black individuals, which may be as high as 2 to 3 times the prevalence and 5 to 9 times increase in incidence. And we do know also that across the world, there's an increased risk observed in East Asians, such as China, Japan, Korea, and Mongolia, versus South Asians, which is India and so on, versus other non-white groups. So the lupus and lupus nephritis prevalence and incidence varies very clearly in the United States by race and ancestry. And it's, as we said before, Native Americans, which include Alaskan Indians, African Americans, followed by Latinos, Asian Americans, and finally Pacific Islanders. And the variation in lupus prevalence can range between 62 to 84.8 per 100,000. The incidence also ranges between about 4.6 to 5.6. The increase in the prevalence and incidence in African American women is very clearly 2 to 6 times higher. And the percentage of women with lupus in the United States who are African American is about 30 to 46%. We see for lupus nephritis, the prevalence then is different between African Americans and European Americans, 59 to 15. Those who develop end-stage renal disease, much higher in the African Americans, increased risk of death from lupus nephritis causing end-stage renal disease, hazard ratios 1.18. And there's a much higher likelihood of admission in patients with lupus nephritis to have either hemorrhagic stroke or heart failure among African Americans. Risk is very important, and what we know is that genetic factors play a key role in this. Susceptibility and severity equal risk. The genetic susceptibility to lupus we have seen varies significantly across different racial ethnic groups. We know that there are several genetic loci that are associated, notable differences in race, and severity and risk of lupus is clearly different among races. And then across genetic ancestries, we've seen that gene expression changes are significantly influenced. There's shared genetic risk variants for lupus across ancestries, but we've also seen that transancestral genetic studies reveal a commonality of shared genetic risk variances, which are clearly predisposing to the development of lupus. But I've shown you before, we need larger studies with wider ancestral representation. There is quite a bit of portion of the globe for which we don't have these studies. This relates to outcome. Ethnicity has a differential impact on lupus outcomes than race. Ethnicity is thought to be self-identified or socially identified. It's more dynamic because it includes multiple factors such as genetic ancestry, but also geographical origin, migratory status, housing and employment patterns, cultural factors. Yet with race, we have ancestral background affecting pathogenesis, susceptibility, as we've talked about, organ involvement, response to medications, but ethnicity may also contribute to this severity and attitudes towards patients. We have 58 genetic regions associated with lupus in European Americans that have not been identified in African American subjects, but some of the 9 genetic regions associated with lupus in African Americans have not been found in European Americans. So the effect of race on clinical outcomes is quite prominent. Disease severity and race are linked. We know that among non-white groups. We know that in terms of comorbidities that are higher. Mortality rates are also impacted by race, disproportionately higher among socially and economically disadvantaged populations. And we've seen that mortality rates are significantly higher among Blacks within the United States. So social determinants of health are closely linked to race. And what we see is that, particularly in the US, race may transcend social economic status and geography in determining mortality. The social determinants of health, or your social economic status, your income, your education, your employment, and stigmatized racial and ethnic groups leads to limited access to healthcare. In the United States, this has a lot to do with insurance coverage as well as access to medications. And this then leads to lower adherence, retention of healthcare, poorer survival. So we think that social determinants of health account for 30 to 55% of outcomes in lupus in the United States. The genetic variability, of course, is very interesting. We have genetic expression signatures that show polygenic scores and specific genetic variants. What's very interesting is we look at 34 gene modules in about 1,500 lupus patients of different descent. And we see that standard therapy affected every gene signature and significantly increased myeloid cell signatures, but that ancestral background significantly changed 23 of the 34 gene signatures. What's also interesting is we see the strongest association among African Americans that they're predisposed to have both anti-RNP and anti-double-stranded DNA antibodies, whereas European Americans typically only have anti-dsDNA antibodies. So the autoantibody positivity is also of great interest. And there tends to be far more autoantibody specificities among African Americans than Hispanics or Europeans. So again, we need more studies of countries with more diverse populations. Participation in clinical trials doesn't reflect the patient base, and we know that already. We've seen that whereas white patients are represented at about 33% of the lupus population, 51% are participating in trials. In comparison, whereas Black patients actually represent 43% of the lupus population, only 14% are in trials. With Hispanics, it's 16% versus 21% in trials. With Asians, it's 13% versus 10% in the trials. So can we change trial participation? Of course, there's online educational courses aimed at improving that, particularly among Black and Latino patients. Using critical race therapy can also help trial participation. But there's concerns. There's racial and racism related mistrust. There's concerns about being assigned to placebo. There are very strict study exclusion criteria, which make it difficult. And there's lupus disease-related concerns. But recommendations from physicians and reputable institutions can help motivate trial participation, as can a feeling on the part of the patient to help the greater good, as well as cultural sensitive marketing of trials. So in conclusion, lupus diversity underscores the critical interplay between race, ethnicity, socioeconomic status, and genetic factors in determining disease prevalence, severity, and outcomes. And addressing these disparities requires a multifaceted approach, as outlined by Dr. Arnaud. And this includes further genetic research, improving clinical trial representation, and addressing these critical social determinants of health. Effective strategies must address biologic and social factors if we're going to improve health equity for all lupus patients. Thank you.
Thank you very much, Professor Strand. Again, as always, an extremely interesting talk, and there's an awful lot to unpack there, and I can see some questions coming in, so please do keep them coming. There'll be lots of those to go through at the end. But again, before that, we have one third talk to listen to, and that's from Professor Guillermo Pons-Estel. He's the director of the research unit of the Argentine Society of Rheumatology in Buenos Aires and an associate physician at the Regional Center for Autoimmune and Rheumatic Diseases in Rosario, Argentina. And he's going to speak to us today about the dilemma in disease control, particularly focusing on his own region and on other patients in low and middle income countries. So thanks very much for speaking to us today.
Thank you, Ed, and thank you all, Lupus Forum, for inviting me to give this perspective, unique perspective of this disease control, and I will try to focus more on Latin American countries, which is highly associated with low middle income countries for what is disease control. So if I can jump, these are my disclosures. And the learning objectives for this part of the talk would be to review the sociodemographic characteristics of SLE patients, and I will try to focus especially in patients from low middle income countries, and especially in Latin America. We are going to examine disease control in this part of the world. We are trying to discuss the dilemma of balancing disease control while using immunosuppression and the risk of infection associated with this treatment. And finally, we are going to try to give initiatives to reduce the impact of social determinants and improve patient education that have been used to try to enhance the clinical outcomes in lupus, especially in Latin America. So the set has been given by the previous talk, and what can I say, what can I extra say about Latin America? So just to give you a framework of what I will try to speak and give you a sense or a flavor of what is lupus in this part of the world. So Latin America encompasses mostly and close to 650 million people living in 12 countries, from Mexico in the north to Argentina and Chile in the south. We are called usually in the literature as Hispanics, but is this totally true? When you see the main language in Latin America is Spanish, but for example, the biggest country in Latin America speaks Portuguese. So the language is different and we are all not Hispanics. Something other thing that it's different is usually these patients are referred as Hispanic patient. But if you see the ethnic background that encompasses all the patients living in Latin America, you can see that the more common ethnic groups is mestizo. And we call mestizo when there's a mix between indigenous people and an European heritage. This is followed by white patients, mulattoes, indigenous, and black, also Asians in this part of the world. But why is unique? Why this puzzle in Latin America is unique? Because we have a wide range of genetic expression. And this is made by that mixture of the native populations living in this part of the continent, that it's bring with a history of almost 500 years of colonialism and different immigration, mostly in the last 200 years, that had led to an important ethnic background that is unique in this part of the world. Also, there's a lot of social problems and inequities, such as poverty, education, health disparity, and this take to an important social exclusion and family deterioration that impacts on how patients feel, function, and survive in Latin America. We have seen from Dr. Strand these images about incidence and prevalence around the world of lupus, but I will try to bring your attention to the right side of the slide where we see the prevalence of lupus around the world. And if we take into account from Peru that almost have a prevalence of 50 patients every 100,000 people, to Brazil with almost 100, this gives us around 275 patients living with lupus per 100,000. And if we consider that we have more than 650 million people living in Latin America, this gives us more or less a figure of almost 500,000 patients living with lupus in this part of the world. And why Latin America are different, or why we consider that we are different. And this is because our Amerindian ancestry, and this has been set up and has been published by a paper by the group of Marta Alarcón, when she looks at the proportion of Amerindian ancestries and the number of risk alleles, and you can see in the figure on the left that while the proportion of Amerindian ancestries increase, you can see that the number of risk alleles for lupus increase, being as much as 2.4 for those who have higher Amerindian ancestries. And not only this, we have seen also by the studies of Marta Alarcón, when we have looked at the Chihuahua studies in mestizos and also in Hispanics living in the US, that this group of patients usually tend to present different genes associated with lupus. For example, you can see here that the IRF5, that is a gene highly associated with the interference signature, is highly associated with mestizos and Hispanics, and it's not so commonly seen in patients living in Europe or in the US. Also, there's a lot of heterogeneity, as has been shown before, in different socioeconomic status around lupus. What we have seen in GLADEL, in the Latin American study group for lupus, is that mestizos patients, as well as African Latin American, tend to present with lower socioeconomic status, and this is statistically different from white patients. This type of patients present with less years of formal education, and usually they tend to have less medical coverage. and this gives a lot of importance to the inequities that we found in Latin America. Also, the clinical characteristics are different. These patients, mestizos patients, tend to have a more severe disease. Here you can see the comparisons of lupus nephritis. Almost 46% of our cohort present with lupus nephritis, and this lupus nephritis is statistically significantly different and more frequent in mestizos and African Latin Americans when compared to whites. Also, mestizos patients usually present with high disease activity scores, as you can see here measured by the SLEDAI, and also they present with more disease activity and more damage. One of the problems that we face in Latin America is also related to diagnosis and to the care of patients with lupus. Here you can see a survey that was done by PANLAR, where we have seen the number of rheumatologists per country. As you can see over there, there's almost one rheumatologist per 100,000 inhabitants in Latin America. These figures and this number are lower, importantly lower, than when we compare the numbers of rheumatologists in Europe, for example, or in the US. So this gives us another important inequity of treating lupus in Latin America. And finally, one of the biggest problems is delay in diagnosis. We have seen that patients with SLE, since the beginning of the symptoms, tend to elapse a time of 2 to 4 years and more than 3 physicians, mostly primary care physicians, until they get to a diagnosis. And this is associated with higher numbers of flares, more use of steroids, more damage, less use of modifying drugs, and more mortality in these patients. And this is another important problem in low middle income countries. So now to set what we understand for disease control, we can use the definition of disease modification. And what is disease modification? Is when we try to minimize disease activity with the fewest treatment-associated toxicity while slowing or preventing damage at any organ in lupus. So how frequently man control disease in Latin America, for example, taken as a consideration of low middle income countries? Here I can show you a study from the Grupo Latinoamericano, GLADEL again, where we look at 900 patients not optimally controlled at cohort entry who were followed for almost 5 years. And what we can see here and what can impact us really importantly here is that 4 out of 10 patients, usually they do not achieve remission or low disease activity with the treatments that we are using nowadays. So this takes us to the current dilemma that the current treatment is ineffective and leads to uncontrolled disease activity, usually organ damage, and increased mortality. But more active treatment with immunosuppressors or biologics may help to achieve better disease control, but with an increased risk of infections, of higher cost, and overall risk of adverse outcomes. So truly, the treatment has changed during the past few years, at least in Latin America. Here you can see a comparison of patients with biopsy-proven lupus nephritis with the baseline treatments that they use in 2 different GLADEL cohorts. The original GLADEL cohort was started in 1998 and followed until 2005, and this is shown in green, and the new GLADEL cohort that was started in 2018. And what you can see is that treatment has changed mostly for the use of antimalarials. We use more antimalarials. We use more pulses of steroids, and we use more mycophenolate while we use less cyclophosphamide. But going back to this dilemma, do you use more immunosuppressors, other type of immunosuppressors, or more biologics? No, as you can see in the right side, for refractory patients, considering only refractory patients, the use of belimumab is as low as 2%, tacrolimus as 12% and rituximab less than 10%. And another drug that has been approved to treat lupus nephritis, such as voclosporin, is not, and it cannot be accessed in Latin America. So here we have another important inequity. And why it's important? Because these treatments are, and mostly the use of steroids, are one of the most important predictors of serious infection. And this also was shown in our patients, where the use of steroids of continuously of doses greater than 15 milligrams per day of the use of pulse of methylprednisolone were highly associated with serious infection in Gladel, while the use of antimalarials may be protective of this. And why this is important also because disease infections and disease activity are also the main causes of hospitalization. And this is something that we need to prevent in these patients. So now going to some potential strategies to try to increase access to self-therapies around the world, and especially in low middle income countries. They may include more visibility on SLE, on the strategies around the World Health Organization to try to increase the budget of SLE care. Also, there's the importance of local guidelines to treat SLE patients. And here I can mention that Gladel has launched in 2018 their first guidelines for the care with conjunction with PANLAR. And now we are trying to launch a new guideline and also more actualized. Also, we need to estimate the burden of the disease, and there's an important need to generate epidemiological research that may influence health policy in this part of the world. Also, we need to encourage the use of generics and biosimilars due to the cost of the medication. Telehealth is important. As I show you, there are low numbers of rheumatologists in Latin America, and we need more access to care. And finally, there's a point on education. Here, let me show you two initiatives that we have launched in Latin America. One, it's mainly driven by Cristina Drenkar and Jurilis Fuentes. They have launched an initiative that it's called Let's Talk About Lupus. This initiative has an important impact on patients and their relatives with more than 100,000 followers in Facebook. And they give a lot of different sessions for lupus patients to try to get a better way to live with this disease. Also, as I said, delay in diagnosis is another important issue in this part of the world. And we have launched another proposal that it's called It Is Lupus, where we try to get in contact with primary care physicians in order to diminish this gap in delayed diagnosis. And these are some of the educational things that we can do to try to diminish these inequities in lupus care around the world. So in conclusion, SLE patients in low middle income countries, especially mestizos and African Latin American, often experience early onset, more severe disease, worse outcome, and significant inequities in the care of their disease. They achieve disease control, require minimizing disease activity with the fewest treatment toxicity and slow and preventing organ damage. But by managing disease in Latin America poses a significant challenge, with just 6 out of 10 patients being able to achieve this disease control. So understanding and addressing SLE to enhance educational and better access to care is crucial to effectively solve this dilemma in disease control. Thank you very much.
Thank you very much, Guillermo. A wonderful overview, and again, so much information to go through there. So, and I also want to thank all of our speakers for speaking to time. It makes my job as a chairperson very easy. So now we go to the discussion. It's often the most interesting part of these meetings. So I think there are some questions already starting to come in the Q&A, and please do enter any more at any time as you'd like to. But what I thought I might start off with a question of my own, because one thing I thought is that's very nice about these events is that we have people from all over the world. So we have me and Laurent are in Europe, Professor Strand is in North America, Professor Pons-Estel is in Latin America. And so I thought perhaps we compare our own experiences on a few subjects that occurred to me while I was these presentations, was that we all talked about how complex inequity, there's this overlap between things like race and ethnicity, between socioeconomic factors, between aspects of the healthcare system and the cost of drugs. And so what for you is the most important of these? So perhaps I'll start, we'll go in order we spoke. I'll start asking Laurent first.
Well, thanks. I think this is a great question. We have heard all the elements are highly complex, highly interconnected, and it's very clear that the spectrum we have in Europe is different we have in other places in the world. But I would like to highlight that Europe itself is very heterogeneous. What you have in the UK is probably very different from what we have in France. And also in France, in the area of Alsace, where I live, is not the same as in the south of France. So I really think that there's a role of healthcare policies. There's a major role, especially for access to care, reimbursement of drugs. And then I think I'd highlight these two economical factors, such as income, which is critical, especially in a healthcare system where you have to pay or co-pay for your drugs.
Great, thanks. And then I'll turn next to Vibeke. How does that compare with North America?
Well, at least for the United States, one of the major problems is we don't have unified healthcare system.
Mm-hmm.
And thus many, many patients who fall outside the system and don't even get Medicare or Medicaid, which is help for those that are really in need. So that's the first thing. But then the second thing is access to medications is determined by payers. We physicians prescribe, but oftentimes it's very difficult to get those prescriptions fulfilled by the payers. And we spend enormous time in our system just trying to get these instituted. So beyond all the other social and economic things that we need to do, we need to fix the healthcare system in the United States. And it is probably the worst of all of the, shall we say, first world. It's very embarrassing for us to see the effects of it on severe diseases such as lupus.
Okay, so we just need to fix the US healthcare system. A small request.
We just need a new election, okay?
And then I'll turn to Guillermo. How does that compare for you?
Well, let me tell you, I believe that one of the most important things, is probably education. Education is highly important to this part of the world. In order to understand the disease, in order to understand adherence to treatment, different things are highly associated with education. And probably the other one, and there's a nice paper by Manuel Ugarte, who compared the Lumina cohort with the Gladel cohort. So he compared two patients called mestizos and Hispanics, some patients from Mexico living in the US and some patients in Latin America. And what we saw is that those Hispanics living in the US, that they are also mestizos, they tend to have a worse outcome. And this is highly also associated with the income, probably is one of the most important things, and also the access to care and the family, how the family can help you to cope with this disease. I believe those are important things.
Interesting, actually, because I was thinking about the UK and I was actually going to say something similar. So UK, we have a unitary healthcare system called the NHS, and everyone has access to the same healthcare. It's all paid by the government. Most people use it. There's not very many people who get their healthcare anywhere else. So theoretically, it doesn't matter where you live in the country. It doesn't matter what your income is. Everybody is in, and the access is the same in theory. It doesn't always work, but in theory. So actually, in my practice, what I see is not really that the healthcare system is offering something different to different people. It's more that the person has to be able to access it. And sometimes you have to fight a little bit to get what you want, to get referred, and to get and also to get the doctor to understand your problems, to get you to give me things. And also you need to, the treatment plan you're being given is quite complicated, and it's quite a lot of work to understand it, all of this. And so I, like Guillermo, I concluded in the end, one of the biggest sources of inequity is the patient's ability to understand all of this and to communicate well, especially if there's language problems, different educational background, maybe grew up in another country where healthcare literacy is different, all of these issues, which hopefully is something that we should be able to do something about without needing to spend huge amounts of money changing the healthcare system or buying expensive drugs.
Can I just highlight the fact that when you look at where the money in the healthcare system is mostly channeled to therapeutic strategies rather than preventive strategies.
Yeah.
In most countries is a maximum of 5% to 10% of total health expenditures. And I think we should really think that again.
That's right. So now I'll take a question that's come. There's a few interesting questions coming up in the chat, and perhaps one that I quite like is asking, how do the presenters recommend that we collect data on ethnicity, race, and ancestry among clinical trials and prospective cohorts in lupus patients? Should it be self-reported? Should it be genetic? Or is it something else? Perhaps I should turn to Professor Strand first. Maybe a difficult question, but do you have any thoughts?
Yes, I think it is a challenging question. I think you basically need to try and do both. So ethnicity is largely self-reported and very much culturally based. But the genetic differences, we at least have some limited ways of seeing those differences. Of course, autoantibodies, but other ways that we're gaining more and more information about. So I would argue it would be both. Of course, at least most situations is self-reported, as is ethnicity. And that's probably the best way to do those. But I think they all need to be reported. Would you agree?
Yeah, actually, I was going to say, we came against this issue recently. I was writing a proposal for a clinical trial, and the peer reviewers asked me some questions like this that were quite difficult, gave us work to do to reply to them, but it was quite useful, actually. And we found there are some guidelines on it have been developed, and there are some things were emphasized, like, first of all, if you have an idea about what your target population is, then you could perhaps, before you start your work, try and engage the population and try and understand what it is you're going to collect and how people would describe themselves. Make sure your investigators are trained in what you've learned and what you've decided. Also, they emphasize, just like you said, self-reported is usually the preferred way to go, but also that it's important to explain to people why are we doing this? What do we hope to learn from it? Important as you go through the trial. And then the other thing that I thought from it, again, from another piece of research I did, was we had the opportunity in a study with rituximab to get in a little bit. There was a relationship between some different demographic groups in the UK and response to therapy, but it was quite confounded by like socioeconomic variables, which we had data for. But normally you don't have it, do you? And it just made me think that to understand actually what you need to collect is not just something like race or ethnicity. You might have to collect some of the other things that might be necessary to understand it as well.
And you have to explain why you're asking these questions, because many times patients will interpret this as some type of racial slur or ethnicity slur. And yet what you're trying to understand better is these disparities and what they're related to.
Exactly. So you might ask educational level or income, but you do need to explain why. Does anyone else have thoughts on that?
Yeah, sure. First of all, I can say that in France, it is actually illegal to collect racial or ethnic background. So that's the first element, except on very special situations, you cannot make a survey collecting these informations. And it sounds a bit strange, but in the way, it indirectly highlights that these are constructs. They are social constructs, and the danger here is to think that there is underlying biological difference, and this is not the case. I think that this data should not be collected. If you're interested in the differential effect of some gene expression, well, then collect these genes and study this element. I do think that racial background or social ethnicity are changing in time, actually, because they're just constructs. And I don't think they are very helpful. I think it would be more collect income, social, economic determinants, although the trials are usually mitigating these differences, but not always, of course.
Yeah, the real reasons is something else. The real reasons for the difference, exactly as that embraced slide I showed, was they thought they were trying to study Black African ancestry, as they called it. And in fact, it turned out that meant a completely different thing, depending on which country you're in, which just shows that probably it meant nothing, actually. And actually,
Thank you. Wow. Oh. Let me jump in this one for a last thing. I will take it to a more practical point of view. You show it that patients in some trials, they tend to respond better to some medications than others. So truly, do we think it's the color of the skin them responds differently, or the language that they use, or it's probably more all the things that we have covered during these talks? So probably that's the proper answer to try to resolve it's things that truly doesn't matter, or if they matter is so low that we have to look at other things.
Can I say?
Predicting the, I'm sorry, it's like predicting the placebo response, which is so much based on expectation.
Yeah.
Interesting. Just published yesterday in ARD, which really recaps these elements and advocates for not using racial backgrounds in the EULAR recommendations for lupus, especially the idea that different population, different racial backgrounds should be treated differently. So I think it's a must-read letter. It's just published in September issue of ARD.
Right, well, look at that. So I think basically what the questioner is asking is exactly right, which is that we need to do, before we can, we think we've got a problem that we want to answer, but before we can answer it, we need the language and the terminology and the methods to even approach it, actually, that we need to develop. Related to that, there's another question here in the chat, actually, which is, Rahul Gupta says, interesting talk. Given the fact the Black population has a higher propensity towards developing SLE, and also SLE patients have a predisposition towards stroke and heart failure, does that mean you've got a population that's more likely to get, I think, those complications of the SLE? This is open to anyone who has a thought about it. My guess would be yes. But with the said, which is that you'd need, so I think it's true that people with SLE who also have risk factors for other diseases that can create a complicated situation, but it's with the provisos we just said that we need to be more granular in how we describe people in terms of the real underlying reasons for that.
And going to that, we have seen that patients, and this is probably also associated with what we have speak here, some patients and some ethnic groups or race groups, as it can be called, they tend to be poor. And if they tend to be poor, then tend to eat different type of food. They tend to develop more comorbidities. So it's truly the disease, or it's truly all the things that also we have been speaking during this forum that are related to these bad outcomes of this. Probably this is something else we should always think about. That is not the ethnic background that leads to a patient to have a worse outcome on comorbidities and other things also related over there.
Yeah.
Also, I think it means we perpetuate expectations that are probably not correct. And so if we can try to alter some of these factors, it could make a big difference.
Yeah, great. Another one, an interesting one. So Laurent, you showed us in a lot of detail how socioeconomic factors influence the outcomes of people with SLE. Can the opposite be true?
So
In
I'm
other
not
words,
sure to
does
understand
having
your question,
SLE,
actually.
can having SLE change your socioeconomic problems?
Oh, of course. I believe I've shown a slide regarding the impact upon employment, the impact of pain, whether it is directly due to lupus or indirectly due to lupus through fibromyalgia, for instance, or type 2 symptoms. So I do think that the burden of SLE is enormous, especially the socio-economic burden. All the qualitative studies highlight the isolation of patients, the disruptive impact of SLE upon normal life. So the answer is yes. I think it's a mutual relationship, unfortunately.
And in children, it might affect their education.
Absolutely.
Oh, yeah.
Yeah. Okay, and another one, perhaps I'll ask this one to Guillermo. How can we improve the outcomes of lupus without needing to buy more high-cost drugs? Are there ways we can do it without needing so much money for these expensive drugs?
Yes, I believe that probably there are many things that we can do. I believe education is crucial. Education to try to understand the disease, to better communicate with patients, education to include more patients in clinical trials. I also believe that patients need this information to try to better understand the disease and to have a better adherence to the treatment. These are things that are quite important. And the other thing is that we need in low middle income countries more information about the outcome, about the clinical manifestations, about how the disease behaves in these patients. We try, or we usually, what we do is we reflect ourselves in Europe or in North America, and what we have seen is that patients living in other parts of the world, usually they don't behave the same. The clinical outcomes are not the same, the response to treatment sometimes are not the same, so it's quite important to have genetic studies, it's important to have clinical studies in these countries to have a better solution for the treatment of these patients.
And another one I was thinking about as you were answering was that we could do more trials for lower cost drugs to use them better. And one example that is coming up now, which I think you mentioned in rituximab, is now a biologic for lupus that we've been using for 20 years. It's becoming cheaper. There's biosimilars, but the trial space is quite weak. And if we could improve that and know how best to use that, maybe we need to be using higher doses more often, certain types of patients, certain compounds. If we could improve that, we could have a cheaper biologic than some of the ones that are being licensed. Another question then. So perhaps this one I'll ask to Vibeke. How can sponsors improve their trial designs to address these issues? I'll give you the easy one.
Sponsors need to do a lot of work on this one. I think among other things, they've been told what the regulatory requirements are. So they turn around and tell regulators, this is what we have to do. But that's not a patient population that will actually answer the question of the trial. So I think, and there's starting to be a lot better work with consortiums of investigators and sponsors so that we can actually design better patient population requirements and ask questions that are more relevant, not just to get a certain drug approved or a certain regimen approved, but to actually find out what is happening to the disease and what's happening to the individuals in the trials. And we see that because oftentimes a phase 2 trial in lupus will be successful when it's a much smaller population, maybe a little bit more homogeneous, only say in Western Europe or the US. And yet when you go to phase 3 and you need to make it multinational, then it becomes heterogeneous and the data aren't as strong.
And the trials, my impression sometimes with the designs is that the non-renal trials that use something like BICLA or SRI4 as an outcome tend to recruit a certain of lupus patients.
That's right. That's right.
Who have skin disease and joint disease and have stable background, which means that the activity is kind of active but tolerable. Because if they were too severe,
Right.
they couldn't do the trial. Right. And this may also exclude some of the populations we talked about. Worst affected by lupus may get knocked out because they're too bad. A lot of young people, I bet, have disease. They have more internal organ involvement. They can't do that. They can't.
Right.
Yeah. So I think there may be designs that are more.
And there's also a fear of enrolling patients with too active disease, too much internal organ involvement, but that it won't be accurately measured. So we need new outcomes. We need definite differences than SRI4 and BICLA.
Yeah, and there's no reason you can't design trials to address any severity of patients. We do trials in intensive care. In sepsis, it doesn't matter how ill you are. You can still do a trial if you just design it to think about that. Yeah.
Do you think there is for the patient associations to engage patients or the communities within the trials?
Yes.
You have perfectly volunteered for the next two questions I was going to choose in the chat. Okay, so there's two questions that just came in the chat while we were talking that both allude to this point. So I will read them both out and you can answer them. So the first one, great talk, thanks. Presentations highlighted the significant disparities in lupus prevalence, severity, outcomes between different racial, ethnic, socioeconomic groups. What are the most promising strategies or initiatives at policy level or within the healthcare system to address these deep-rooted inequities and improve access to high-quality, equitable care for all lupus patients, regardless of their background? And I think we spoke to some of those points at the end, but the very last part of that is exactly what you said. What role in the lupus community, including patients, providers, and researchers, play in these changes? And then I have to tell you a related question, which is from Jeanette Anderson, who we know works for Lupus Europe, and she asks, so investing in patient education and patient organizations might have the biggest impact on treatment. Would you like to comment a bit further?
Yeah, sure. I do think that these patient associations, Lupus Europe and the others, LFA, have an extraordinary capacity to engage the community of patients. But, because there is a but, obviously these associations talk or communicate with specific patients. There is a channeling bias here. And the true problem is, how can we reach the true minorities? I don't really like this word or this expression, but the patients who cannot read actually, or the patients who are not speaking the language well, those are the most deprived patients and those that are the less represented in the trials. And this community of patients is difficult to engage, even for patient associations, despite the amazing work that they do.
Yes, I agree. We had this in the UK with Lupus UK. We had this same discussion. As there's a lot of information available through the patient organizations, but how can we tailor it to the different people, their educational needs or their language or beliefs about healthcare and things like that. That's the
I
challenge.
believe it can be done, but this is a tremendous effort, but it's probably worth it.
So the answer to the question of should we invest in this, I think, is a resounding yes.
Yes.
Because I think
Yes.
we all agreed that reducing inequities doesn't just rely on buying expensive drugs or changing the whole healthcare system. It may just be helping people to access it, helping people to use it, and communicating. So I think we could probably go on talking for a very long time, but we're getting near to the end of our time available. So I just wanted to, at this point, thank everyone for attending. Just to remind you that you're going to see a short evaluation form to provide some feedback. And please, we really do think about the feedback that you give us. It helps us to decide what content we're going to offer, what are going to be the subjects of future webinars. And in fact, that's how we got the idea for the webinar you've been watching today. So you'll also get your EACCME accreditation by completion of that questionnaire. This, like all of our content at Lupus Forum, this webinar is going to be available on the Lupus Forum website and on the YouTube channel. So if you want to watch it again or ask your colleagues if they might want to watch it, please feel free to do so. If you haven't done already, sign up onto the Lupus Forum so that you get our emails and you'll know whether there's anything new out. You can access everything old, and you can also follow us on Twitter and on LinkedIn. So with all of that said, all there is left for me to do is to thank you for listening, and also thank all of our speakers for these excellent presentations and fascinating discussions. We'll see you again next time for our podcasts and for the next time that we have a webinar like this that's live. Thank you.